Hello, my name is Britt Houwen. I'm a PhD candidate of the Amsterdam UMC. I'm here together with my supervisor, Evelien.
My name is Evelien Dekker. I'm a gastroenterologist here at the Amsterdam University Medical Centers and my specific focus is on colorectal cancer and advanced endoscopy techniques.
Yeah, and we're here together because gastrointestinal endoscopy invited us to tell a little bit about our article that was recently published in their journal. And the title of the article is Guidance for Setting Easy to Adopt Competence Criteria for Optical Diagnosis of Diminutive Colorectal Polyps, a Simulation Approach. And Evelien, maybe it's nice to start. Maybe you want us to tell a little bit what motivated us to set up this study.
Yes, so nowadays using very nice endoscopes with also the possibility to visualize the mucosal pattern of the polyps very well, the optical diagnosis is increasingly important for decision making during endoscopy. We can do that by ourselves as endoscopists, but also AI systems are currently coming on the market to help us and assist us in performing optical diagnosis. It's possible when we would be able to diagnose a diminutive polyps properly to, for example, leave small diminutive hyperplastic polyps in the rectosigmoid in situ without a risk for the patient, and other diminutive polyps could be resected but left in the colon and not be collected for pathology. And this of course would save a lot of costs during endoscopy, but also reduce the burden for the patients. For safe implementation of this strategy, however, competence should be demonstrated for endoscopists and as well as for AI systems. And currently the competence of the optical diagnosis strategy is done by the PV criteria as proposed by the ASGE. And it's the only way we have nowadays in our hands. However, it's relatively impractical to use them, because first of all they use MPV in the rectosigmoid, so for small polyps not being an adenoma. And the problem is that most endoscopists already leave small hyperplastic polyps in situ, so there is no proof, no evidence that they have a proper and accurate optical diagnosis there. Besides, surveillance intervals should be correct using optical diagnosis strategy, which is also a relatively more complicated measure to use for several reasons. One is that most surveillance intervals are based on diminutive polyps, but also on larger polyps that we don't use the optical diagnosis strategy for. And on the other hand, because surveillance guidelines vary between countries. However, PV is the only thing we had nowadays, and alternatives are lacking. And that was the reason for us to try to develop more easy to use competence criteria for daily practice.
Yes, so when I was in the beginning of my PhD, we talked with several people about how we could come up with an alternative for the PV. This finally has led us to Veerle Coupé and Marjolein Greuter of the Decision Modeling Center of the VU Medical Center. And in collaboration with them we set up this study in which we systematically assess the proportion of diminutive polyps an endoscopist or AI system has to diagnose correctly to meet the current PV criteria. And what we did in this simulation approach is that that a virtual endoscopist or an AI system performed optical diagnosis on all diminutive polyps in a cohort, and an endoscopist or AI system was doing this with a fixed performance level on all people in the cohort. And for example, one virtual endoscopist diagnosed 80% of the adenomas correctly, 80% of the hyperplastic polyps and 40% of the sessile serrated lesions. And for this endoscopist we calculated the agreement with the PV criteria. In total we defined 756 strategies, and we did this simulation approach. We did it in two different data sets. One data set was a primary colonoscopy screening cohort data set, and the other one was a large FIT positive screening cohort data set. And for calculation of PV1 we used the European and the American guideline. And what we finally found was that the proportion of correctly diagnosed diminutive polyps to achieve that agreement with the PV was very high and dependent on the clinical setting and the guideline that was used. If we look at the primary colonoscopy screening program, 92% of all polyps had to be diagnosed correctly, the diminutive polyps, to achieve PV1, while for reaching PV2, so the MPV, 89% of all diminutive polyps had to be diagnosed correctly. And for the FIT screening setting, the numbers were a little bit different. Was 77 to reach PV1 and 94 to reach PV2. And what was quite remarkable is that when we used the European guidelines instead of the American surveillance guideline to calculate the surveillance interval agreement, the PV1 was already met when 40% of all polyps were diagnosed correctly. And compared to the PV criteria, maybe this proportion of correctly diagnosed diminutive polyps represents an easier to adopt competence criteria to measure competence in optical diagnosis, or at least we think it might be easier. But of course the question remains what an expert remains to be clinical acceptable. So Evelien, you're an expert of optical diagnosis, in optical diagnosis, so yeah, we're very curious, what's your opinion about this?
Yeah, that's a good question. I think first of all, when performing endoscopy doesn't mean that you also are good in performing optical diagnosis. So you have to be trained to do so. And with the ESGE, the European Society for Gastrointestinal Endoscopy, we have described a curriculum explaining that first of all you should be a good basic quality endoscopist, so look very well at the mucosa, be assessing a proper bowel prep, all those things, and then need to follow a validated training to be able to make an optical diagnosis. And there are several classification systems available, like the NICE or the WASP or the BASIC. There are several of them, and then when using those systems you have to be able to reach an endorsed competence standard. The same for AI systems, of course. They should also be able to meet that endorsed competence statement. And of course, experts then need to decide what should be that threshold that we should meet, and which threshold would have acceptable clinical consequences, so for the patient, without too much risk.
Yeah, so in the end, of course, then what's important for the patient would be an increase in in colorectal cancer incidence or mortality, and we're also interested in what's the risk of leaving in a diminutive adenoma. However, the numbers on this topic are very limited. For modeling studies, they all show that when you implement the optical diagnosis, this only marginally increases the colorectal cancer incidence. If we look into the risk of leaving in a diminutive adenoma in the rectus sigmoid, there's one very nice study. It's come from Japan, from the group of Sekiguchi, and they show that in 5-year follow-up, none of 508 untreated diminutive adenomas progressed into advanced neoplasia. However, yeah, it remains a fact that there is a risk of implementing the optical diagnosis strategy. However, we think if we select average risk patients and meet the proposed training and competence standards like Evelien was talking about before, this risk can become quite small. And maybe I think to end, maybe it would be nice to discuss a little bit about the future. What are the next steps, or what do we have to think about in the future?
Yes, so we have made all these calculations, and now we need consensus for practicing endoscopists. So we probably need consensus meetings to decide on an acceptable clinical criteria and thus clinical consequences for the patients, and then we need to also think about setting up an accreditation system and a monitoring system, because maybe if you once accredited you will remain competent for the rest of your life, but it's also very well possible that time by time you need at least to assess again your competence. So that's still some work to do. That's for endoscopists, but of course the same would be the case for AI systems.
Yeah. So yeah, as you notice, we can talk a lot about this topic, but for now I think we would like to thank you for your attention, and please, if you have any questions about this study, please feel free to contact us. We will be happy to respond. So thank you, and bye-bye. Bye-bye.
Bye-bye, thank you.